Electronic health records were supposed to modernize medicine. They were supposed to reduce errors, improve coordination, lower costs, and free clinicians from paperwork. Instead, they are widely disliked by doctors, nurses, and administrators alike. They are blamed for burnout, inefficiency, and endless clicking that seems disconnected from patient care. The question is not whether EHRs feel bad to use. They clearly do. The question is why. The answer is not poor software engineering alone. It is institutional design. To understand why electronic health records function the way they do, we have to look at how they were adopted, what they were designed to optimize for, and whose incentives shaped their evolution. The modern EHR system in the United States did not emerge organically from clinical demand. It was accelerated by policy. In 2009, the federal government passed the HITECH Act as part of the stimulus response to the financial crisis. The goal was to digitize healthcare records rapidly. Hospitals and physician practices were offered substantial financial incentives to adopt certified EHR systems and penalties if they did not. This created urgency, but urgency came with conditions. To qualify for incentives, providers had to demonstrate meaningful use. That phrase sounds clinical. In practice, it meant compliance with a long list of reporting requirements, documentation standards, and measurable behaviors. EHR vendors did not build systems primarily to make clinicians' lives easier. They built systems to help institutions attest compliance. The core customer was not the physician at the bedside. It was the hospital system responding to federal rules. As a result, EHRs became compliance engines first, and clinical tools second. Every checkbox, drop-down, alert, and mandatory field exists because someone, somewhere, needs data for billing, quality reporting, risk adjustment, or regulatory attestation. The interface reflects the needs of payers, auditors, and regulators more than the cognitive workflow of clinicians. This is why documentation feels excessive. EHRs are not just medical records. They are billing instruments. They are legal records. They are audit trails. They are risk management tools. Clinical care is only one function layered on top. The second institutional force shaping EHRs is reimbursement. In the U.S., payment depends on documentation. Diagnoses must be coded. Procedures must be justified. Complexity must be demonstrated. Risk must be captured accurately. If it is not documented, it did not happen. EHRs are therefore optimized to produce billable artifacts, not narrative clarity. They encourage templated notes, copied text, and structured fields that map cleanly to codes. This is why notes are long but uninformative. The system rewards volume and completeness of documentation, not readability or clinical insight. A note that satisfies billing requirements may obscure the actual story of the patient. Now, consider interoperability. From the outside, it seems absurd that hospitals cannot easily share records. The technology exists. Data transfer is trivial in many industries, yet healthcare systems routinely fail to communicate. This failure is not primarily technical, it is economic. Healthcare data is valuable. Patient relationships are valuable. Control over information confers leverage. EHR vendors sell systems to competing hospital systems. Those systems do not want to make it easy for patients or clinicians to move between networks. Interoperability reduces switching costs. Lower switching costs weaken market power. As a result, data exchange standards exist on paper, but implementation is partial, inconsistent, and often deliberately inconvenient. Interoperability is treated as a regulatory obligation, not a competitive advantage. When systems do exchange data, it is often through intermediaries, portals, or limited summaries, rather than seamless integration. The friction is the feature. This fragmentation also reflects the structure of U.S. healthcare itself. There is no single payer, no single delivery system, no unified patient identifier. Each institution maintains its own records, governed by its own incentives and legal constraints. EHRs mirror that fragmentation. Another often overlooked factor is liability. Healthcare is highly litigious. Documentation is defensive. Alerts proliferate because failure to warn carries legal risk. Pop-ups exist not because they help clinicians think, but because they demonstrate that the system warned them. Over time, alerts accumulate. Signals buried under noise. Clinicians learn to click through warnings reflexively, undermining their original purpose. This is not a software bug. It is a governance outcome. The system optimizes for institutional protection rather than human attention. Now consider who EHRs are designed for. Large hospital systems dominate purchasing decisions. Their priorities include enterprise reporting, revenue cycle management, compliance, and analytics. Small practices and individual clinicians are marginal buyers. EHR vendors respond accordingly. User experience for frontline clinicians is sacrificed to enterprise functionality. Customization is limited. Workflows are standardized to support scale, not nuance. Once implemented, switching costs are enormous. Training costs are high. Data migration is risky. Downtime is expensive. Institutions become locked in. Vendors gain pricing power. Innovation slows. This is why dissatisfaction persists without exit. From an institutional perspective, EHRs succeeded at what they were asked to do. They digitized records. They enabled billing at scale. They standardized reporting. They made healthcare legible to regulators and payers. They were not designed to optimize clinical cognition, narrative reasoning, or human-centered care. That gap produces frustration. Could this have been different? Yes, but it would have required different incentives. If reimbursement rewarded outcomes rather than documentation, EHRs would look different. If data portability were enforced as a competitive mandate, interoperability would improve. If clinicians, rather than institutions, were the primary customers, interfaces would change. But institutions respond to rules, not aspirations. Electronic health records are not bad because software engineers failed. They are bad because the system asked them to be something else first. They are the mirror of the healthcare system that built them. Understanding EHR dysfunction is not about blaming technology. It is about recognizing how policy, payment, liability, and market structure shape tools. Until those incentives change, the experience will remain the same. For continued institutional analysis of how rules and incentives shape healthcare systems, subscribe.